Hello, the time is now 7 p.m. Eastern, the official start time for today's broadcast. The topic today is providing and financing new evidence-based behavioral health approaches in primary care. And now, without further ado, I'd like to turn things over to your host, Stacy Hull, Behavioral Task Lead for Alliant Quality. Stacy, the floor is yours.
Thank you. Good evening, everyone. I would like to thank you for participating in Alliant Quality's Learning and Action Network event tonight, and for your continued commitment to provide quality health care. Before we get started, I would like to remind you that in addition to the monthly Quickeners, Alliant is available to provide free personalized technical assistance to you and your staff. We can assist with trainings on process flow, motivational interviewing, and behavior health resource coordination, just to name a few. I invite you to take advantage of these services and to reach out to us. I would like to remind you that the depression codes you see on the screen, as well as the alcohol screening codes on the next screen, are both Medicare reimbursable codes. We invite you to utilize these codes in your practice. At this time, I would like to share some information about our speaker. Dr. Lori Rainey is a board-certified psychiatrist and principal with Health Management Associates in Denver, Colorado. She is considered a leading authority on the collaborative care model and the bidirectional integration of primary care and behavioral health. She is the editor of the book, Integrated Care, Working at the Interface of Primary Care and Behavioral Health. She is a master trainer for the American Psychiatric Association's Transforming Clinical Practice grant to train 3,500 psychiatrists in the collaborative care model. Dr. Rainey served 15 years as the medical director of a community mental health center, where she fostered the development of a full range of evidence-based services. During her tenure, she led efforts to implement the collaborative care model in diverse primary care locations, tribal clinics, and school-based health centers. Please enjoy the expert advice of Dr. Lori Rainey.
Thanks for the invitation to be here today. This is certainly a topic near and dear to my heart. There are new billing codes that have come out for Medicare about 2 months ago, and we're going to focus on the evidence base of integrated care and also new financial financing opportunities for that model. Just real quickly, this shouldn't be news to anyone on this call, but there are some serious problems with patients getting to behavioral health providers. If you have 10 patients with a diagnosed behavioral health condition, about 6 of them receive no treatment. About a little more than 2 actually get their care from the primary care provider, and a little less than 2 actually from a mental health provider. The 60% is a huge problem. Lots of reasons why people don't get care. And in the primary care settings, one of the issues is it's very difficult for primary care providers to provide adequate treatment. Much of that is because of training issues. And so what we saw in actually this Phil Wang study is only about 20% of the care was considered to be minimally effective. And again, that is as much about training issues, but also about measurement and being comfortable with the medications. So when we start talking about collaborative care, we start talking about integrated care, what we're really talking about is that there's a sweet spot for this, and it's treating mild to moderate mental illness in the primary care setting. It is not necessarily about treating the most severe patients in terms of bipolar disorder, schizophrenia, schizoaffective disorder. The sweet spot for this model for doing this work is actually in the treatment of mild to moderate mental illness. One of the things it can do, though, if we do it successfully, is really keep people from moving along this triangle and their illness actually getting worse because it's gone untreated. So let's talk a little bit about what the collaborative care model is and why it may differ from other models of integrated care that you might be used to. A lot of things are called integrated care. Having a psychiatrist come share an office in your clinic, having a social worker come do a co-located psychotherapy, having a psychologist kind of be there and available and go in and out of exam rooms and kind of address anything that's going on. Collaborative care is much more specific than that and has a very robust evidence base because it adds 2 things that you don't tend to see. One is there's a concept of measurement-based care, and you treat to target. Just like you would diabetes or anything else, you really go for a specific target. I'll show you that in a minute. and it's population-based care. When you do population-based care, you really do have to track who your patients are. You have to have a data tool like a registry in order to be able to really be accountable. If you do all these things, you can be accountable to your Medicare, ACO, and other payers. And let me show you how that goes. So on the collaborative care team, what you do is you add 2 new people, the behavioral health provider and a care manager. These are the same person. In the field, you will hear people talk about BHPs. You will hear people talk about the care management role. I guess at some point I'm just going to call them behavioral care managers so I can blend the 2 words. But you're adding this person who tends to be a psychologist, social worker, a licensed professional counselor. You're adding that person to the team. And then you're also adding a consulting psychiatric provider who can be a psychiatrist, a psychiatric nurse practitioner, or psychiatric physician's assistant. Those are the 3 categories that you'll see later are important to the code. So that's what we're adding to the traditional PCP, MA nursing, patient sort of triad. There can be other behavioral health folks in the clinic, alcohol, substance use counselors, other folks, but the key folks here are the addition of this behavioral health person and the consulting psychiatric provider. What it looks like in the clinic now is we really work hard to get patients activated around their illness, but you can see in this slide the gal in red is a social worker. She's right there at the elbow of the PCP if possible, although some of this is now being done electronically through tablets and telemedicine. They are able to talk about the patient who you see in the background, really right there to start the behavioral health treatment for the patient. And then behind that is an enormous amount of practice support. Using this measurement-based treatment to target, we're going to talk about the PHQ-9 in a minute. Readily available psychiatric consultation, that's me and my cell phone. If a PCP calls, I answer the phone and help them out. Using the registry, there's an example of the registry, and then providing training. And the evidence base for this model is incredibly robust. There are over 80 randomized controlled trials now. This original study was in older adults. There's now the full range of age ranges, including children. We've got ADHD studies. We've got adolescent depression studies. We've got depression. We've got anxiety. We've got studies in payer populations, Medicare populations, rural areas, urban areas, safety net clinics, African Americans, Latino patients, Asian patients. There is just an incredibly robust evidence base. And the other thing we have in this model is an ROI, a return on investment. In the original impact study 4 years down the road, the return on investment was about $6 for every dollar spent. Now remember, that's a robust study with lots of money, so I wouldn't expect necessarily that ROI, but certainly an opportunity to do pretty well with this model. The process starts with validated screening and measurement tools. You just heard Dr. Mims talking about reimbursement around depression screening. It's certainly something very much encouraged in primary care. This is the PHQ-9, the most used now in both research and in primary care. It is literally the 9 DSM-5 symptoms of depression, rated from not at all to really happening most days. The cutoff point for let's do something now about this is as a score of 10 or above. That's considered moderate depression. Between 5 and 9, we're calling that kind of a mild depression. Do some little watchful waiting, and certainly 15 and above, we got moderate to severe depression. Less than 5 is considered remission. So when I was talking earlier about treat to target, for psychiatrists, for all of us, the holy grail in behavioral health is really remission of symptoms if we can get there, and certainly in depression and anxiety. So I'm always pushing, trying to get that PHQ-9 score below 5, and that's extremely important for this model and what we're trying to do. This particular patient, you can see, has a PHQ-9 of 15. That means we're going to get activated that person into this model and begin to move. One of the most important people in this model is definitely the primary care provider, whose job is to engage the patient, pitch the project, the program, the care to the patient, and how they do that is extremely important. And we actually have scripts for PCPs to help them, because if they start off with, this is behavioral health condition, I think you need to see a therapist. I'm going to refer you down the hall. You can certainly get resistance from the patients. When they connect with this behavioral care manager, there's some very specific things that need to be done in order to reach the evidence base, in order to reach these outcomes and the ROI. The first is these behavioral health folks are doing evidence-based brief interventions proven to work in primary care. Most of us are familiar with motivational interviewing, but there are things like behavioral activation, problem-solving therapy, solution-focused brief therapy, teaching patients deep breathing as a distress tolerance skills that are very effective. The other thing that is really core in this model is this frequent, persistent follow-up. So what this little study right here shows is if patients get 2 or more contacts from this behavioral health person in a month, dramatic in terms of the quickness to response and how well they do overall. So this is actually something that is now crucial to the model, and this BEO study really helped show us that this needs to happen. And in some forms of integrated care, this doesn't happen, and hence we don't really get to see the evidence base. What's also happening at these frequent, persistent follow-ups is multiple times repeating PHQ-9 or the GAD-7 if this is an anxiety disorder. So we're now doing this as much as once a week, once every 2 weeks now, doing the PHQ-9. This is not once a year. It's not twice a year. Every single visit, every single contact, repeating the PHQ-9, which is very valid for this purpose. The next thing that the behavioral care manager is doing is placing this data in a tracking tool called a registry. And this is a free registry you can download from the AIMS website. You can see both the PHQ-9 and the GAD-7 here. You can see the initial scores of 22, 18, 14 in this in the column on the left. You can see the last available score. Patients are either getting better or they're not, and then the percent drop. A clinically significant reduction in PHQ-9 in particular and GAD-7 is a 50% or more reduction in symptoms, and as I mentioned earlier, remission is a PHQ-9 less than 5, and you can see the patient at the bottom has a PHQ-9 of 2. They're now in remission. You can also see the person before that kind of fell through the cracks. There is no score, and something's happened, and we need, if we're going to be accountable for this population, maybe the group in your ACO, you need to have a way to track that person. The psychiatric consultant's doing 2 things. They're doing curbside consultations, answering the phone when you call, and they're doing a weekly caseload review where they sit down and they go through this registry and really just focusing on the patients who aren't getting better and making recommendations. Now, there are specific performance measures that you can be held accountable for in your clinic, and we're seeing a lot of this now in Medicaid ACOs. Depression remission at 6 and 12 months are now a standard quality measure, but as I mentioned before, that 50% reduction in PHQ-9s is considered a clinically significant response. That's an NQF, also National Quality Forum quality measure, but the percent reaching remission is becoming a bit of a gold standard, and remission is tough. With depression, it's a difficult disorder to treat, so we have to be careful. There's also very specific process measures. The repeating of the PHQ-9, the having the registry, the weekly caseload review, the 2 contacts or more by this care manager. These are all process measures that we're now learning absolutely lead to the robust evidence base and performance that we have with this model. You can also do patient satisfaction, and what we're seeing with PCPs is pretty incredible provider satisfaction, also functional measures, and of course cost and utilization. The cultures of primary care and behavioral health are quite different, so we have to have some strategies, some things that we can do to overcome some of these cultural differences. There's a really nice study that shows, what does it really take to make this model work, and some specific things are really that strong PCP champion, at least one PCP in the clinic who's very excited about this model and really willing to do things differently, but also an engaged psychiatric provider. If this person is working with the clinic, reviewing that registry, really working and doing support for that clinic, we really see really robust outcomes. So there's sort of the process measures, the key, these sort of core principles that we talked about of measurement-based care and population-based care. But then there's these process of care tasks, that 2 or more contacts a month, tracking, repeatedly measuring, and then this review. So, and then the last thing that I went over was these intangible factors, I guess we could say. The strong leadership support, that PCP champion, the role of the care manager. You don't have them off doing social work. They're not off doing transportation and housing and those sorts of things. They're really engaged in those behavioral strategies. And, you know, just really knowing that you have that buy-in. And these things are difficult to get. You really have to have people within your clinic who understand these barriers, who understand the potential pitfalls and what might happen, and really have a mechanism to work around them, real people skills, real excitement to help make this work. So if you put all of these things together that I've been talking about, this is kind of a summary slide where I bring together the core principles, those process of care tasks, and this, I call it sometimes the squishy stuff in between, the people part of this. This is kind of your recipe for success in an integrated care model. Now let's go a little bit to financing, because this is kind of the bugaboo of integrated care. It has been for years. There hasn't been, there's a lot of stuff that goes on that's not billable. These brief interventions, sometimes they're too brief to bill. If a patient doesn't have a diagnosis, maybe those huddles in the morning, the hallway conversations that you saw going on between the social worker and the primary care provider, kind of that warm handoff. Calling the psychiatric provider and getting some, recommendation on what to do. Calling patients, repeating these rating scales on the phone. Now, you heard earlier there's some depression screening that can be, paid for if you're into this, you got this 15 minutes of screening, but this is more repeating these measurement scales over and over again, often on the phone. Having team meetings where you're bringing primary care and behavioral health together and you're sitting down, maybe talking about complex patients, maybe just talking about your model and what's working and what doesn't. And all that time the care manager spends with the registry. The registry is practically their organizing document of the day. It tells them who to call, who to follow up with, who needs to be talked about with the psychiatrist, and who needs any additional follow-up. So these tend to be the things that can't be coded, can't be billed. So we say in the field, what works can't be coded. Many of these are those core principles and those core tasks that I just talked about. So what's happened recently, and again, this is sort of what we're very excited about, is beginning January 1st, CMS came out with new, and you can see these are G codes for right now. These will be 99 permanent codes, CPT codes, effective January 1st, 2018, and that's because CMS updates the physician fee schedule every 2 years. CMS is so interested in this model getting picked up. Remember, most CPT codes start with Medicare, so Medicare is where you can bill these right now. They were so interested and excited about getting this on the street, they came up with codes that can actually be billed effective January 1st of this year. And so let me just kind of go through these codes. What I want you to notice is these codes go right down the evidence base. The previous 20 slides that I showed, these are the tasks that you must do on a monthly basis to bill these codes. This code is billed once a month by the primary care provider. The primary care provider then uses the resources from this code to hire this behavioral care manager and to hire for the psychiatric time. So the code is billed by the PCP, not by the psychiatrist, not by the social worker. It is billed by the PCP. In the first month, the GO502, this is up to 70 minutes of time spent working with the patient, so it's a little higher than the GO503, which is subsequent months, where there's about 60 minutes, maximum of 60 minutes considered for this code. Now, as you guys know, with Medicare, when you get halfway there, you can actually go ahead and bill the code. So in the first month, if it's 36 minutes, the second month, if it's 31 minutes of work by this care manager and psychiatrist, then the PCP can go ahead and bill the code the minute they hit that. There's some specifics around this. We don't have time to discuss right now, but a couple of things. There has to be an initiating visit by the PCP. There has to be at least verbal consent that's documented in the chart, not so much signed consent. And the patients do have their standard Medicare copay of 20% unless they've got some kind of Medigap insurance. So that's just kind of a starter on some of the background stuff. But look at what's required. Outreach and engagement by this behavioral health provider. Remember those 2 contacts a month that I talked about earlier. Initial assessment and then continuing the use of these validated rating scales. That you must have a registry and you must track the patient's progress. Once a week, typically, you sit down with the psychiatric consultant and review those patients who aren't getting better, and then doing these brief interventions I talked about earlier. That is what is expected of the team in order for you to be able to build these codes. So, and you have to meet the minute requirements. There is an extra code, a GO504. If you spend an extra 20 minutes or more with the patient during that month, let's say the patient's suicidal or something of that nature, and more time is needed, then you can actually bill an additional $66 under this code. So we are very excited about these codes. We're really watchful about clinics that are beginning to implement them and really helping people overcome any barriers in terms of this implementation. Okay, that kind of wraps that up, and I'd love to entertain questions or comments.
And before we get started with some additional questions, I have one, if you don't mind, Dr. Rainey. So I'm thinking I'm a primary care clinician in a small rural town. I'm assuming that collaborative psychiatrist does not need to be located nearby, but are there some parameters on who can fulfill that role as the collaborating psychiatrist? Do I have to have a contract with them? Do I have to? Do they have to be within my state? And how would I go about finding them?
Yeah, so there are, they do not have to be on site. Most of these are remote. If you look at Washington State, almost all the psychiatrists are in Seattle, and they're beaming out to 200 to 300 primary care clinics across, especially very rural eastern Washington. They can be a psychiatrist, a psychiatric nurse practitioner, or a psychiatric PA. They cannot be a prescribing psychologist. They cannot be a just standard psychologist. It's got to be someone who can prescribe medication. What the PCP does is contract with the psychiatrist. It's usually 1.5 to 2 hours per care manager with a full caseload. Full caseload tends to be, we say, 60 to 80 patients on that registry. So that kind of helps you think about, well, what might that cost be in terms of that psychiatrist. And then the APA is, like you mentioned earlier, training 3,500 psychiatrists to do this work, and they're all, after they do the training, very eager in your states to find training sites. So we now have lists of psychiatrists all over the country who have been trained to do this. We're also looking at what it would be like for the psychiatrist to do these registry reviews across state lines. A little bit of a gray area legally, but it's sometimes considered peer-to-peer consultation, which is usually allowed in most states. So that's a little bit of a gray area for us right now.
So I would contact the National Association to find someone local for me to work with?
Yeah, and I can help you guys look at that. The American Psychiatric Association has that list. They also have a great training for PCPs now, 2 modules on their APA website, the American Psychiatric Association website. And I could help direct you guys to that because I'm one of the master trainers, and I'm sure I have trained people in your states already.
Thank you very much.
And Dr. Rainey, we have a question that was submitted by chat. Thanks for the presentation. How are these new codes being promoted or disseminated to providers? And how can we help get the word out?
Yeah, that's really, they are so new. What we're finding is a lot of primary care providers don't know about them. I have been working in Colorado with our regional Medicare organization that sort of covers multiple western states, and they said it just takes time. They're waiting for additional guidance from CMS, which came out last week. The APA is promoting it. We're trying to get AAFP and other organizations to promote it, but it takes some time, and typically these more regional Medicare organizations are responsible for training and notification of all the new codes. I don't know who does that in your area, but everything from knee replacements on, there are lots of new codes that come out, and your regional Medicare organizations are responsible for disseminating those codes. But I would say any chance you get, any website, any newsletter, whatever it is, let's get the word out there.
Thank you. I will turn it over now to Stacy Hull.
Thank you. I would like to thank you all for joining us tonight. Our next webinar will be held on August 17th at 12:30. Dr. Tiffany Cook will present on understanding and applying the SBIRT model, an efficient approach for primary care. We will also host another evening webinar on August 24th at 7 p.m. Dr. Chanowski will present on integrating care for the whole person, collaborative teams for behavioral health and medical conditions. Thank you again for joining us, and if we can be of assistance, please reach out. Have a great night.